always changing, and understandably, I'm not criticizing it. We're building the plane while we fly it. But what happened was it generated a lot of confusion in the public. And there was fertile ground for the spread of misinformation, disinformation, and conspiracies, not only through social media, but also mainstream media. So we need to be more consistent in the messages that we as a community share going forward. And ideally, we should create echo chambers. If you look at how effective communication happens, it's usually by repeating the same message over and over again. We also need to address myths and misconceptions and misinformation. We have to address it directly. Ideally, not by debunking them, by pre-bunking them. You anticipate what's going to be said, and you have the information circulating already to prepare people for the lies. And we have to engage stakeholders productively, and we have to use language that they understand. So to address these challenges, what we did is to use a human-centered design approach to do research in a few countries that were selected based on the limited access to diagnostics, limited demand, and synergies with the other diagnostic advocacy efforts. There were 22 key expert interviews at the global level. Some of you were interviewed for this. There were consultations with civil society organizations in the countries, and then interviews with policymakers, influencers, and communities in these 5 countries. And what we saw, if the remote control works. Yeah, there you go. So we basically started, this is qualitative research. These are unstructured interviews with a lot of observation. And we started collecting information about the policymakers. So for example, policymakers, some of them argue that testing should be part of routine testing. If you look at health workers, some of them expressed the value of rapid tests. They understood how it was important to increase access to testing. And if you look at communities, for example, one of the quotes here is about self-treatment. It's a very common thing for people to self-treat before they test. So you start, as part of this qualitative research, you start looking for patterns in the behaviors that you see and the comments that are made, and aggregating them into specific topics. So in this case, one of the factors influencing policymakers is the belief that communities are not interested or capable of self-testing. It's an interesting quote. Even though lots of effort towards sensitization, there's very little demand for testing as communities do not see COVID as a threat. People care more about cancer than COVID. Another example is the skepticism about the private sector engagement. When in fact it should not be if we engage the private sector, it's how we engage the private sector. And this is in the context of policymakers. It doesn't always work, huh? I'm going to move closer. All right, so this, at the community level, this is another example. It's a preference for self-treatment. So the quote is, because all the tests and examinations at the hospital are expensive, I prefer to start with self-medication. And if that doesn't work, then I'll go to the hospital. Or it's the unclear benefit associated with testing. That's a very common thing. It's the understanding the value of testing. So we basically aggregate all of this, and we develop a number of messages, and then pre-tested the messages in different settings, using Facebook, and through meetings that were convened by Find, and other meetings that were convened with other partners, and we produced this toolkit. So let's talk about the toolkit. So a picture is worth 1,000 words, so a movie is probably more than that.
81% of people in low and middle income countries do not have access to testing. Policymakers are overwhelmed with multiple health priorities, while community members often access treatment without testing. The COVID-19 pandemic has affected every person in every country in the world and exposed the global gap in diagnostic access. Never has there been a more opportune moment for us to refocus our efforts to ensure everyone has access to the right test at the right time across diseases. Introducing the Let's Test Toolkit. Using evidence from field research in multiple countries, we have designed a set of communication assets for advocacy and demand generation that can help you convince policymakers and communities of the value of testing. We know that advocacy happens in a lot of ways, and we've designed for that. From quick conversations to more in-depth official meetings, you'll find tools to address the concerns that policymakers might have. We also know that you have to meet communities where they are, whether through digital tools or in-person communication. You're in charge, from design to delivery to monitoring. All tools are easily adaptable to your local context. Download the toolkit by going to lets-test.org or scanning the QR code. Access to testing is a global effort, and the work you do in your community moves us all closer to our goal. Together, we can keep our communities healthy. Let's test.
All right, so here's the structure of the toolkit. It's divided basically in three parts. So the top one is basically background information about target audiences, the diseases, and the factors that hinder access to testing. And then the core of the toolkit is the messaging matrix, which is we're targeting two audiences, policymakers and communities. Policymakers, because what we saw during the pandemic was that policymakers were gatekeepers. It doesn't really matter what happens downstream. If a policymaker does not understand the importance of testing and prioritizes it in the national response or in the national health plan and budget, it doesn't matter what happens downstream. You're not going to access testing. So we need to relieve this bottleneck at the very top. And as you can see here, we have, do I have a pointer here too? A pointer. No? No, it doesn't work. It doesn't work there. So you can see that we have three different types of assets: digital assets, videos, static posts, and GIFs, the conversation started tool, and a modular PowerPoint deck that could be separated to address specific issues with the policymakers. And then you have the community side. So the policymaker side is advocacy. The community side is social behavior change. That's much more tricky because it's context specific. We'll talk about this in a moment, but you have the digital assets there as well, same thing, and we have interpersonal communication tools, including games, quizzes, and other things, and role-playing. And then the third part of the tool is how to use and to adapt the assets. So the principle here is that, you probably know the saying that you can give them the fish or teach them how to fish. If you teach them how to fish, they become independent, autonomous, and it's sustainable. What we're doing is both. So we're creating these assets that are ready to go. You press the button and you can use it. Or we're also, we're giving you assets that are editable. You cannot change the background, but you can change the words to your local language or the message in order to make it relevant to your local context. And then we provide instructions, if you have the time, the resources, and the interest, to actually do the proper research to adapt the tools. So let me give you examples. So the policymakers, after all of the psychosocial research on the ground, we basically arrived at 10 main factors. So what's the value of testing? Do communities want to test, and can they correctly self-test? And I'm not going to read all of them, but I'm going to give you an example of number 5, which is, can lower-level facilities and community health workers provide testing? Each page of those 10 pages is organized like this. You basically have, at the very top, what is the question, an explanation of why this is relevant. So the reason why we're addressing this is because the research identifies skepticism about the feasibility of community-level testing among many decision makers. So then you have sub-factors associated with this main factor, which are shown here. So, for example, these are static posts that can be shared on social media. Around the world, community health workers have shown that it's possible to provide a range of services previously restricted to health facilities. And another one is there are over 3 million community health workers globally. Imagine if each one could also provide testing as a standard service. So this is advocacy with decision makers. These are static posts, but we have a number of GIFs as well. There's no sound. So these are to be shared on social media because we found that GIFs are more engaging. There's also another option, which is we have panels that have a story around it. So this is a very good one. The cost of test goes beyond the price of the test itself, something we often don't think about. It includes transport to the nearest health center, a full day of wages, or childcare. So other tools that were developed for decision makers is this conversation started. As you can see, the cards on the left side, they basically start with a question at the very top, the answer, an explanation, and then a relevant quote. So for example, the red one is about universal health care. We have modular PowerPoints, as I described, and the tools, and we have some animations as well.
81.
But I'm going to skip it because you have seen it already. The same thing with communities. So the communities is different because, as I mentioned, it's social behavior change. So we basically focused on two main things. One is the value proposition of testing. And the second one are myths and misconceptions. So the list of myths and misconceptions that we found to be predominantly found in many countries are listed on the left side. And then we have these posts that basically, so we have the static posts on top. You have animations, short animations between 30 seconds and 1 minute. And then you have in-person games and quizzes that would allow community health workers, could be community health workers, could be civil society organizations, community-based organizations, or advocacy champions to engage with the communities and increase the level of literacy and understanding of the value of testing. Here are two examples. You see on the left side, without confirming a result, self-medication can waste time, money, and have a negative effect on your health. So the question is shown there, why can't self-medicate instead of testing? So the last section, shown in red, is how to adapt the tools. So in this section, we provide recommendations on how to contextually adapt the tools. Oops. Yeah, that's fine. So on the left side, and basically, these are the policy worker, the policymaker tools, and how they can be used for meetings, for messaging, for large technical meetings or online. And then on the right side, the community tools. And finally, and I'm not going to get into the details because this is another large part of the toolkit, is how do you actually go about adapting the tools? So identifying the disease, identifying the target audience, selecting the priority factors, reviewing comms and objectives, and adjusting the message and the assets. So one thing I want to say, because it caught me even by surprise, the amount of work that was done around this. So we narrowed down to a total of 26 factors between policymakers and community members or communities. These main factors were broken down into just over 50 messages, and these 50 messages were packaged in 163 assets from a range of things, from the toolkit itself, PowerPoint presentations, static posts, GIFs, posters, panels, animations, games, and so on. So the attempt here, what we're trying to do is use evidence to create a foundation for the community to advocate. And you can pick and choose what you like or what you do not like. And if you want to adapt it, you have the option of doing that as well. In the finalized versions, the UNICEF logo will be there, and the adaptable version, we're removing the logo because we cannot take responsibility for what people will say. And I'll be happy to answer questions. And this is the last slide. Can you go back one? Yeah, so if you want to access the tool, you just scan the barcode or go to let's-test.org, let's-test.org. And we're going to have a webinar launch on Thursday, June 8th. And please go to the website and register for the webinar if you want. If you cannot attend, it will be recorded and will be available afterwards. Thank you.
Thank you so much, Alex. Are there any questions from the audience for Alex while we've got him here? Oh, there's one over there.
Thank you for sharing. Just a quick question. I might have missed it at the beginning, but is it focusing on any specific tests in particular?
No, not really. So we started with COVID. It was happening at the time. But what we did was to collect information from COVID and generalize based on the challenges that we were encountering. And we know that it applies to a number of other diseases as well. So it's based on COVID, inspired by COVID, but it's disease agnostic, and it's focused on the challenges of testing. In the toolkit, you will see messages that are specific for COVID, but there are a small number of them. And there's also a focus on PCR and rapid tests. There's some of the messages that talk about the two of them.
Any other questions? It's a terrific resource. Thank you so much. Oh.
Hi, Alex. Has UNICEF considered making another version of what we used to call the Blue Book for task shifting? That UNAIDS, WHO did the first one, then UNAIDS, WHO did the second one that wasn't very great. But to have one specific to administration of tests, what kind of test, and who could do it, and at what level. And I know it's obviously very test specific, but it could be very helpful to get UNICEF's imprimatur, as well as WHO, to then make the advocacy more successful at the national level for winning the policy change. So Lesotho that presented earlier, I think it was the only government that spoke. So the change in policy that we community health workers, but they also had lay health workers administer tests and even had some people in lab helping with basic work inside district level labs. But that would be something that could be very helpful, I think.
Yeah, I agree. I would actually approach the WHO for this. We can work with them, but in terms of normative guidance, very often the WHO is the organization that has the responsibility and the mandate to do it. We can work with them on this. And the second reason why I'm saying this is because a lot of this advocacy is also internal to UNICEF. UNICEF vaccinates 50% of the children globally, but when you talk about testing, people start looking at you like, what, we don't do this, the WHO does. It's like, no, not actually. If you actually look at UNICEF as a frontline organization working in communities and primary healthcare, we are doing it all the time, but the capacity is not there.
Can I say something though, because that sets us up for a problem, because there is no one person at WHO, nor a department that looks at diagnostics across pathologies, right? So you would literally, if you wanted to do another blue book, you would literally have to go to every disease department. So what we need really is a focal point. We need a Sherpa. So until that happens, Alex, you're going to be my point of contact on all things blue booking.
I accept it.
Can I just make a point as we're talking about advocacy and the resolution coming up? So they are forming a task force to get that central point into WHO because it's a requirement by the resolution. So fingers crossed that it actually passes about now. If that does, at least we have a person we can start chasing. It will then take some time for them to build up, I think, that internal coordination. But the minimum thing that this resolution is going to do to force finally that central point about questions diagnostic, not disease specific or IVD versus imaging, etc.
Next to
My name is Hoon Sang Lee from the Rai Foundation in Korea. Very interesting materials, I think, that can be used very well, I think. But I was wondering, there are whole another movement and initiative to expand the role of the community health workers. And there are so much of the enthusiasm in that league right now. Also trying to expand the role of primary health care and people-centered primary health care as well. Is there any kind of like interaction with, I mean, UNICEF are also actually part of that effort as far as I understand, but is there any kind of intersected efforts or coordination between these two efforts to In one sense, there is effort for expanding the role of community health worker or establishing very robust community-based primary healthcare system, and there is this laboratory efforts, testing efforts. What is the status of the communication or coordination between two efforts?
So I can't speak about the coordination. I think it's necessary. It's very important. What I can tell you is that we have a new executive director. It's been more than 1 year. And her well-defined priority right now is community health and primary health care. And this is sort of where UNICEF is a sweet spot, because we're a frontline organization working in this space. And what we're trying to do with this work is also to promote the decentralization of testing. So this falls under the priorities for the organization. And very much in line with the lessons learned from COVID-19, that centralized systems weren't able to deliver to those in need. And we need to decentralize. And you see the funding is going more in this direction as well, for decentralized testing and decentralized provision of health services. So this is another tool to advocate for decentralization of testing. And I think what's important is for those of us working in this space to really coordinate. So
and provide much more stronger argument for the decentralization of the healthcare and primary healthcare strengthening, maybe.
Yes, but one thing that's very important is the funding. I think the donors can actually drive a lot of that. And you see the Global Fund, for example, or some of the pandemic frameworks that are being developed right now advocate for more decentralization of testing and strengthening of primary healthcare and community health. From our point of view, we are actually advocating for the professionalization of community health workers. They're not volunteers. They're an extension. They are outreach of the health system. And in fact, we have a program, Community Health Roadmap, which has a register or registry of the community health workers in a country, so working in partnership with the government. You understand who they are, what they've been trained for, where they operate and what they can do, and you remunerate them, you pay them appropriately. They're not volunteers, they're qualified workers. And then by doing this, I think we're gonna have a much more robust system that is able to reach into the communities and refer it to the primary health care and higher levels of the health system when necessary.
Thanks so much, everybody. If there are no more questions, I think we're just about at time. So huge thanks, Alex, for sharing this with us. I think it's a very exciting resource.